Hello and welcome. My name is Jessica Adelman. I am the Social Media and Communications Manager for the Ehlers-Danlos Society, and I will be your moderator today. For our webinar today, we have Dr. Pradeep Chopra presenting on connecting the dots with EDS, POTS, MCAS, GI, neurological, and physiotherapy in managing pain in EDS. This webinar is part of our ongoing series, Living with EDS and HSD. A quick note about how this webinar is going to work. Attendees are muted at all times in listen-only mode. However, you are able to type questions into the question box at any time. Dr. Chopra will not be able to see or respond to any questions until the Q&A time at the end of his presentation. Please do not send your questions more than once. It will not increase the chance your question will be answered. It will only make it harder for us to sift through all the questions. The awesome Dr. Chopra is a pain management specialist with a special interest in complex pain conditions. His background in residency in anesthesia and critical care, fellowship in pain management from Harvard Medical School. He is currently an assistant professor at Brown Medical School and works full-time as a pain medicine specialist. He has a special interest in complex pain conditions and their associated coexisting conditions. Dr. Chopra is Pain Management Working Group Chair on the Ehlers-Danlos International Consortium. Thank you so much, Dr. Chopra, for being here with us today.
Thank you, Jessica. Thank you for the introduction. So my name, as you all know by now, is Pradeep Chopra, and so this presentation is about connecting everything that's in EDS. Over the next few months, and you'll hear presentations from different specialists on different aspects of this. But what I wanted to do was to bring it all together. So how does each one of these conditions that EDS comes with connects with other conditions? It's a really complicated discussion today, and I don't want you to worry about missing something because this is going to be recorded. It's going to be there on the website, and I assume the slides will be there too. And you can so don't worry about writing notes as much as about trying to understand what's going on. So this is my standard disclosure and disclaimer. I have no actual or potential conflict of interest to this presentation or program. And I'm going to mention, this is the first time I'm going to do this actually, I'm going to mention names of some of the products that I actually recommend to my patients, and I have absolutely no financial interest in those. And we'll talk about a lot of things that are off-label use of medications, and this discussion is only for general information purposes. Please discuss with your physician your own particular treatment. This discussion is not meant to take the place of your doctor. So Jessica's already gone through this. I did my training and fellowship in Harvard Medical School. I'm a weird pain medicine specialist. And I'm also an assistant professor at the Brown Medical School here in Rhode Island, USA. And the reason I'm a weird pain specialist is because I have a special interest in complex pain conditions. Okay, that doesn't make sense. EDS is a complex condition, we know that. So I'm going to do some connecting the dots here. So you see over here, we have EDS, and then we have so we have EDS, and then we have joint instability, POTS, tethered cord syndrome, mast cell activation syndrome, abdominal pain, Chiari, autoimmune dysfunction, craniocervical instability. And this discussion is going to bring all of this together and find out its relationship to EDS. There are three things, well, actually four things to know about EDS. Firstly, I need you to understand that EDS is not a disease. It is a form of the human body. So there are tall people, short people, black people, white people. So there are all kinds of people that look different. They have different body structures, and they have their own medical conditions. And these medical conditions are particular to their body form, and it has nothing to do with it being a disease. The other thing I need you to know is that people with EDS have soft connective tissue. Connective tissue is tissue that connects everything in our body together. Our joints, our muscles, our ligaments, our skin, everything is connected to each other by what is called as connective tissue. And connective tissue in EDS is softer. It's softer than those without EDS. The third thing to know is that people with EDS have poor joint position sense, which is officially known as proprioception. And I'll get into that later on. The tough part about EDS is that it comes along with a few coexisting conditions like mast cell activation syndrome, postural, orthostatic, etc. Not quite sure how they are related and what's the situation here, but for now we just know that they come together. So I didn't know where to start from, so I'm just going to start with body region, pain in EDS by body regions, starting from the head. Over here I've listed about 9 common reasons for headaches in EDS. I actually did count the total number of causes, and there were about 25 of them, and I've taken out the rare ones. So these are the more common causes. Migraines, it's hard to say migraines are common in EDS because migraines are common in general and they're more common in women. So it's hard to say. Chiari Malformation, cervicogenic headaches. These are headaches that come from muscles attached to the head. Temporomandibular joint dysfunction, that's the TM joint. POTS can cause headaches. Spontaneous CSF leak can cause headaches. Craniocervical instability, that is instability of the neck and head, can contribute to headaches. And there's something called idiopathic, which means unknown, intracranial, inside the head, hypertension, so raised pressure inside the head. So if someone comes in says that my head feels too heavy to hold up, the thing that we look for is posture. Do they have a chin poking forward position? Over here, you can see where the neutral position should be your ears in line with your shoulder. Oftentimes, in fact, most patients with EDS that I have seen have what is called a chin poking forward position. So the ear is in front of their shoulder joints. The problem with that is that when they're in a neutral position, the head weighs approximately 10 to 12 pounds. That's the equivalent of a bowling ball. And you have to imagine a bowling ball balanced delicately on the neck. When this bowling ball or the head leans forward by 1 inch, which is not a whole lot, the pressure on the head and the neck is now about 20 pounds. It doubles. When the head leans forward by 2 inches, the pressure is about 30 pounds. So it becomes almost 3 times. So having your head in a 2-inch forward position almost triples the pressure that's applied on the neck. Now, a common cause of neck pain is posture, of course, and it's usually one of the reasons is using a smartphone, which is now what we call as a texting neck. So looking down at the phone, constantly texting, is one of the more common reasons. The chin poking forward position. Now, the reason I brought this up right in the beginning is because before we talk about any of the other fancy conditions like Chiari Malformation, look for this. This is much easier to correct than to treat cervical instability or Chiari Malformation. What does a poor posture, what does a poor neck posture do to you? So ideally, the ear should be in line with the shoulder, which makes the shoulder square, which then balances right through. So the weight of the body goes right through the pelvis, into the legs, through the knee joints, and into the foot, where the center of gravity is at the sacrum, the S2 level. When you have a chin poking forward position, these patients start to develop neck pain. They present with back pain, SI joint pain, this is a joint in the lower back, and then they continue to present even knee pain and foot pain. How do you find out what the correct position should be? The easiest way to do is stand leaning against a wall with your buttock touching the wall, the shoulder touching the wall, and your head touching the wall. And your feet should be about 6 inches away from the wall. And that will give you an idea as to what should be the correct position, what should be your correct neutral position to hold your head and neck. So why do people with EDS have poor posture? One of the things is they have blurry vision. There are lots of reasons for having blurry vision. The commonest reason for having blurry vision in EDS is actually POTS. They have difficulty focusing. It usually comes and goes depending on how potsy they are on a day. POTS itself can cause poor posture. Loose spinal ligaments can cause the head to poke forward, and instability of the head and neck. So how do you fix this? One of the things to do is, it's actually pretty difficult to place your index finger in front of the chin and push it back gently, push your head back gently till you feel the ears are in line with the shoulders. And you know when the ears are in line with your shoulders is when we tested the previous picture over here, standing against a wall. The other one is to use a large monitor, sit well balanced while working on a computer. When you're using your phone, when you're using your smartphone to text, bring the phone up rather than look down at the phone. And of course, manage POTS. And we'll talk about that. What if my whole head hurts? I see double, and I can feel my heartbeat in my ears. So my whole head hurts. I see double, and I can feel my heartbeat in my ears. This is a symptom of idiopathic intracranial hypertension. That means the pressure inside the head is high. These patients present with constant severe headache. Nothing really works. They've tried all their migraine medicines. They've tried the usual treatments. Nothing has worked. They start to have vision issues. They have double vision, sensitivity to light. One of the most important things they do have is a ringing in the ears, which pulses, which is called pulsatile tinnitus. The narrowing, the pressure in the head goes up is because they have a sinus. There's a venous sinus, so the vein in the head is narrowed. So in about almost 73% of these cases have one or the other vein that has become narrow. And when that becomes narrow, there's a back pressure inside the head, and they have a raised intracranial tension. The diagnosis is to do a spinal tap. We're now moving away from doing spinal taps as a diagnosis because in EDS, it's a different presentation. We don't do spinal taps anymore now to diagnose intracranial hypertension. An eye exam and something called an MR venography, which means they basically inject you with a dye and then they look at the flow, and that tells them exactly which vein is particularly narrowed down. The treatment for this is there are certain medicines like acetazolamide that decreases the fluid pressure inside the head, and then they can go in and put a shunt to drain the excess fluid, or they can put a stent to open up the vein. My headache gets worse when I stand, and it almost goes away when I lie down. So in these patients, the headache gets really worse. It gets really, really bad when they stand up, almost immediately. And it actually almost goes away when they lie down. When I say lie down, I mean lying down flat, lying down supine. This is a symptom of what is called as a spontaneous CSF leak. CSF is, there's fluid pressure. So the brain and the brain and the spinal cord float in a fluid, and it's a closed compartment, and this fluid keeps circulating around, and there's no leak. And if it does develop a leak, if this CSF starts to leak out, then the pressure inside the head drops, and when the pressure inside the head drops, it pulls on the lining of the head, and that causes a headache. So obviously, when they stand, the pressure is the highest at the bottom and the lower back, and there's more leaking, and when there's more leaking, there's a higher chance of getting a headache. When they lie down, then the pressure equalizes everywhere, and they don't get as much of a headache. So like I said, these headaches get worse being upright. They resolve with lying supine. So that it's not inclined, it's not reclined, it has to be flat. It usually gets worse by the end of the day because you've been standing all day. In long-standing cases, the headache is all day long. And the reason I bring this up is because it's very often it's missed in patients with EDS. Most times we look for when a patient presents with CSF leak, we look for any history of a spinal tap or an epidural or something like that. But in patients with EDS, this leak can happen even without any trauma, without any spinal taps. And so it's missed for many years. And so eventually they wind up having headache all day long. They have nausea and vomiting. They do have ringing in their ears, but this is not a pulsatile ringing. It's just a constant ringing, which gets worse when they stand. They present with neck pain. I put this over here is because we'll talk about POTS later on, but what I wanted to show you was the headache gets worse in POTS also when they stand, and they both present with headaches. The headache gets worse when people with POTS and CSF leaks stand, but when patients with POTS, the headache in POTS does not get significantly better with lying down. It gets kind of better, but not a lot better. And usually my cutoff is 50%. If there's a 50% relief, then I think of CSF leak. If it's less than 50%, I think more of POTS. They do have neck pain, fatigue, and nausea. And of course, orthostatics is the measurement of your heart rate and your blood pressure. And in CSF leaks, there's no change in the orthostatics. But in POTS, the heart rate goes up by 30 beats per minute with no change in blood pressure when they stand. People with POTS present with dizziness. People with CSF don't really often present with dizziness. So how do you manage CSF leak? You increase your PO fluids, oral fluids. You increase that. Increase caffeine. I mean, it has to be a lot of caffeine. It can't be just drinking a cup of tea. So what I tell my patients is to take Excedrin migraine, which has a boatload of caffeine in it. Using an abdominal binder, it increases the CSF pressure. They can go in and do an epidural blood patch. The only thing with doing an epidural blood patch is it has to be done by somebody who's well experienced. And most times people need multiple blood patches to see a response. You may see a response for the first one, but a lot of people need have it done multiple times. They can, in some centers, they can actually, if they know exactly where the leak is, they can inject fibrin glue into the epidural space. And then, of course, if it's not going to get better, then you have to do a surgical repair. Surgical repair is often done in patients who've just had back surgery and now having CSF leak, and it's not getting better with anything else. Then they have to go back in there and close it up. It works well. So just to recap, if my headache gets worse when I stand and it almost goes away when I lie down, is a symptom of spontaneous CSF leak. Okay, so my headache gets worse when I cough, I have tingling in my hands and feet, and I have difficulty swallowing. So my headache gets worse when I cough, I have tingling in my hands and feet, and I have difficulty swallowing. This is a symptom of what is called as Chiari Malformation. So I'm going to teach you a little bit about Chiari Malformation. This is the brain, and this is the skull. Most of us have a brain inside our skull, and this little yellow cabbage-looking thing is called the cerebellum, and it's responsible for balance. so balancing as we walk, balancing, that's what this cerebellum does. This little thing, this pink purple thing is called the brain stem. And so the brain pokes out through a hole under the bottom of the skull called the foramen magnum. And that's what a normal skull looks like with the brain inside. In Chiari malformation, for some reason, this space where the cerebellum sits is small. Just by birth, it's small. And so what happens is it pushes everything down through this hole in the skull called the foramen magnum. So the brainstem gets pushed down, the cerebellum gets pushed down. Actually, it's not the cerebellum, but it's a part of the cerebellum. They're called tonsils. So the tonsil gets pushed down. So everything gets squeezed through this tiny hole over here. And these patients present with a unique set of symptoms. These are, the most important one is they have headaches in the back of their head called the suboccipital region. That's where their headaches are. They have neck pain, they have balance problems. Remember, it was the cerebellum that was getting pushed down. They have numbness or tingling in their arms and legs. This numbness and tingling actually gets worse when they cough. They also present with dizziness. Now, this is one of the things I want to keep pointing out again and again is that these symptoms can happen for other reasons. Neck pain can happen because of craniocervical instability, or neck pain can happen because somebody is really being a pain in the neck in your house. So neck pain has many reasons. I don't want people to think that, oh, just because they have a neck pain, it's Chiari malformation. Dizziness can happen from POTS. It can happen for a bunch of things, difficulty swallowing, poor hand coordination, which is again a function of the cerebellum. And these headaches get worse with coughing or straining. So these are some of the more critical points that I look for, at least. Headaches made worse by coughing or straining, and especially the headaches are in the suboccipital region, which is the back of the head. Remember where the cerebellum was? So the headache is worse in this part of the head. Besides that, they have other stuff like ringing or buzzing in the ears, hearing loss, nausea, muscle weakness. These are more non-specific findings in these patients. So how do you make a diagnosis? The diagnosis of Chiari malformation depends on a really good history and physical examination. So somebody who knows what Chiari malformation is must take a good history, get all the information in there, do a physical exam. And the other way to do that is to get an upright MRI of the neck. And I'll explain to you why an upright MRI of the neck is important. In people with the EDS, you can diagnose Chiari malformation without an upright MRI. They can just be basically do a regular MRI lying down. But in patients with EDS, the head, that's the cranial settling, the head kind of settles down because the ligaments are loose. The head sort of settles down over the neck when they're in an upright position, and so you can actually see the cerebellum starting to poke through. And I'm going to show you this. So in this slide, these are two MRIs of the same patient. The one on this side is supine, so this one is the patient is actually lying down, and in this one the patient is sitting. Let's look at the one that's in the supine position. This is the foramen magnum. Remember the brainstem? So this is the brainstem poking through the foramen magnum. Remember the cabbage-like structure, which I said was the cerebellum, and now you can see the cerebellum over here. And this is the foramen magnum here. And as you can see, it's not poking down through the foramen magnum. It's not poking down through that hole. The brainstem has got plenty of room around it to move around. When the same MRI was done in a sitting position, you can see how the cerebellum starts to poke through, and now you see the tonsils are actually below the foramen magnum. They're poking right through the foramen magnum. The brainstem is starting to poke right through it, through that hole in the skull, the foramen magnum. So that's the reason why neurosurgeons like to see an MRI in the sitting position for Chiari malformation. On a slightly different note, there's an angle called the clivoaxial angle. This angle is this big name. You don't have to worry about remembering it, but the clivoaxial angle is normally about 140 degrees. So in this patient, in the sitting up position, you can see this is the angle. This is the angle that's measured, and you can see it's about normal, 141 degrees. But as soon as this patient sits up, the angle becomes much more acute, and it is now 133 degrees. We'll talk about this clivoaxial angle a little bit more later on. So what happens when this brain starts to poke through the hole in the skull? The other thing it does is it obstructs the CSF flow. The CSF that's the fluid in which the brain is balanced, which surrounds the spinal cord. And so this CSF flow is now hampered. It's not flowing as smoothly. And so CSF pressure can go up. There's something called the empty sella syndrome. What is called because of this pressure change inside the head and because of the Chiari malformation, there's this gland called the pituitary gland. The pituitary gland is an extremely important gland that controls a lot of functions in our body, like functioning of our thyroid gland, functioning of our adrenals, etc. And this pituitary gland starts to get flattened out, which means basically essentially disappears. And of course, that results in hormonal changes. So patients will start to present with hormonal changes because the pituitary gland is no more visible on these patients. On a side note, in EDS, there is a connection between Chiari malformation, craniocervical instability, and tethered cord syndrome. And I'll get into that a little bit more with this. My recommendation is usually if someone gets diagnosed, somebody with EDS gets diagnosed with Chiari malformation, should get themselves checked for tethered cord syndrome because the incidence of both of them being together is pretty high. It's almost 70% chance of somebody with Chiari malformation having a tethered cord syndrome. So just to recap, my headache gets worse when I cough. I have tingling in my hands and feet, and I have difficulty swallowing as a symptom of Chiari malformation. I should have also mentioned that this headache is more in the back of the head. So moving on to the neck. So the neck is a very delicate structure. It's got 7 vertebrae, and it's really balances the head, which is the weight of a bowling ball, and all of this is stabilized by a gazillion ligaments. All these ligaments hold the neck together, they hold the head together, and at the same time allow for movement of our head and neck in all sorts of directions. Any looseness of these ligaments can cause these joints in the neck to move abnormally, and that's called craniocervical instability. Patients with craniocervical instability, or what's called CCI, present with the usual neck pain, stiffness, headaches, dizziness. They have this tingling in their face. They may have numbness in their one side of the face, fatigue, poor sleep, nausea. It affects their vision. It causes symptoms of POTS, really. They have anxiety, they are lightheaded, poor balance, difficulty swallowing. So this is again what I was trying to explain to you earlier, is that these are very non-specific symptoms that other conditions can also present with these same symptoms. So the imaging for craniocervical instability is again, we need what are called dynamic films. So what we do is we like to see a CT scan with the head in a flexion position, head rotated, the neck rotated to the left 90 degrees, rotated to the right 90 degrees, and then there's the one I missed out over here, which is extension. So we want the neck in these 4 positions at least, and this helps surgeons understand how much is the radiologists to understand how much are these vertebrae moving in relation to each other when you move your head and neck. So the measurements that usually neurosurgeons like to look at are what is called the clivoaxial angle, uh, and that's the normal values there. There's something called the Harris measurement, and there's something called the Grab-Mapstone-Oakes measurement. I'm not going to go into great detail about this, but the reason I brought this slide up, the purpose was to tell you that when getting these, when you have your doctor order an MRI for craniocervical instability or even Chiari malformation, is to ask the radiologist to get these measurements. They can do them on their equipment. They can actually measure these angles, and that does help physicians understand what's going on with the neck, whether the brainstem, because the Grab-Mapstone-Oakes angle will measurement shows you whether there's any ventral brainstem compression, which means if the brain, remember the brainstem, that was this part of the brain sticking out through the hole under the head, whether that is being compressed or not. Now, managing craniocervical instability is rather difficult. If it's mild to moderate instability, what we usually recommend is strengthening the neck muscles. Once you strengthen the muscles that surround the neck, it helps support the neck much better. Using a hard cervical collar, I'll show that to you. And of course, if the instability is severe, then you'll have to think of a surgical fusion. The point I want to make over here is that this is not something that should be taken lightly. Remember, you have a 12-pound head resting resting very delicately on the neck, and any jerky movement of the head or neck can have bad results. Like even a small fender bender in the car could set off can trigger off a serious condition. So what I like to recommend is the Vista MultiPost therapy collar. The reason I like this collar is because of this little cushion here. There's an air cushion inside, and you can actually pump it up according to fit you well. And this is one of the reasons why I like it. There are many other brands out there, but this is the one that I'm most familiar with, and I like it. It's called the Vista MultiPost therapy collar. This is a quick slide I wanted to show you called the Barry-Lewis syndrome. Not too many people understand this condition well, but what I just wanted to point out is one of the possible reasons why people with craniocervical instability also present with symptoms of POTS. Over here, you can see this is the spine. So this is the neck here. Plastered against the neck in the front is this nerve, this chain. It's called a chain, and this chain is part of the sympathetic nervous system. This sympathetic nervous system is the one that's responsible for is part of the autonomic nervous system that can trigger POTS. It's responsible for flight and fight, and it's actually literally stuck to the front of the vertebra. Now, if somebody were to, if this spine was unstable, then it would knock against this, it would stretch these nerves. Stretching the sympathetic nerves would then result in symptoms of difficulty swallowing, tongue numbness, blurred vision, ringing, dizziness, neck pain, and headaches. It can happen in non-EDSers also after a car accident. Soft neck collars are useless. They're just neck warmers. I absolutely don't recommend them. Let's talk about temporomandibular joint pain. This is a joint that makes up the jaw. So the joint lives in front of the ear. So this is your ear, and the joint actually lives right here. And I would say almost 99% of the patients with EDS that I see have temporomandibular joint dysfunction. What's the distribution of pain? I've drawn it over here. You can see this is the distribution of the pain. It's usually on the side of the head, side of the jaw, even goes into the back of the neck and down over here. These patients present with clicking, so the jaw clicks. They have clenching and grinding mostly at night. They have pain with chewing. They have difficulty opening their mouth wide. So anytime they yawn or take a big bite, it gets stuck. So while I'm on this, I wanted to talk a little bit about dental issues in EDS. Uh, a lot of the patients, not all, but a lot of the patients have teeth problems and gum problems. These teeth are weak, they are thin enamel, they are prone to cavities. Doesn't depend on the dental hygiene, and it's a lot has to do with their teeth being, their enamel being soft, and I call that soft teeth. Uh, their gums, that's again, teeth is connective tissue, gums are made of connective tissue. They have gum weakness. They are prone to having gingivitis. They bleed easily, and when they have any gums get damaged when you eat food or brush. It doesn't heal easily. Their tissue breaks down easily after surgery, like a tooth extraction. Gum recession is extremely common, and then they have pocketing, which is these little pockets between the gum and teeth. They have a crowding of the teeth is extremely important. In fact, crowding those teeth is actually one of the diagnostic criteria for the hypermobile type Ehlers-Danlos syndrome. They have a very high incidence of gingivitis. Gingivitis means inflammation of the gums, and that's where all your bacteria go and live there. And anytime you eat food, you swallow this bacteria then spreads into the blood, and they cause inflammatory reactions in the body. There's a higher incidence of diabetes, higher incidence of arthritis in patients. In researching all the types of dental care stuff, that I came across Livionex. Livionex is not the usual dental toothpaste that I've seen. Most toothpastes that you buy over the counter they're abrasive, and so they basically are like sandpaper. You scraping off the stuff off your teeth and gums. Livionex has a different mechanism. What it does is it chelates it, so it sort of grabs the stuff, it grabs the dirty stuff off the teeth and the gums and takes it off. One additional benefit is they don't have salicylates, they don't have gluten, sugar, chemicals, or color dyes, which most people with EDS react to. There are no harsh abrasives. Remember, they have soft teeth, they have soft gums, so they don't have any harsh abrasives. This is not, as far as I know, this is not available in stores, but you can buy it online. I believe you can get it on Amazon, or you can get it directly from the company. So Google it, you should be able to find it. In the last, I think I've been recommending it for the last 2 or 3 years, and I've had great results with it in my patients with EDS. So I really would recommend using this. Numbing medicine. Most people with EDS don't respond to numbing medicine, lidocaine. They go to the dentist, they get a boatload of lidocaine, and they still don't get any benefit from it. The magical numbing medicine is called CarboClean. Now, CarboClean, we found that for some reason, CarboClean, also known as mepivacaine, works well in patients with EDS. Not 100%, but in most patients, it does work well. It's called CarboClean. So next time when you get a dental procedure, or if you're getting local anesthetic, you can request. You may have to make this request before the appointment, so they have it in stock when you go there. So moving on to upper back pain. So we've done the head, we've done the neck, we've looked at teeth. Moving to upper back pain. Again, a lot of the upper back pain is because of poor posture. And the poor posture is because they have a chin poking forward position. The ligaments are loose. They're not really supporting their upper back. And so they tend to sort of lean forward. It can also be from shoulder instability, rib subluxation, doing repetitive tasks with their hands or arms, like typing, vacuuming. It puts a strain on their tissue, and I'll explain to you. It's called microtrauma, and this microtrauma, like this small bits of trauma that happen to the joints of the hand, shoulders, and arms, that results in tissue damage, and the tissue takes a while to heal. So this happens. In women, it can be the weight of the breast tissue. So, essentially what happens is the ligaments in the back support these patients backwards, and then there's ligaments in front of the body that support the patient in the front. But in women, because of the breast tissue, especially if they have large breast tissue, that can cause an imbalance, and so they tend to lean forward. One of the recommendations was to use a sports bra. It helps upper back pain, it helps with shoulder, it helps with something called thoracic outlet syndrome, which is fairly common in patients. The recommendations for using sports bra is to have wide straps, a front closure, because you don't want to overstretch the shoulder joints. It should be proper fitting. Now, proper fitting means the way to do that is to go to a departmental store, ask for somebody who can actually measure and give them a right size. I put this slide in here because I wanted to show you what I meant by a racerback. This racerback is way too low. It's not going to support the upper back. We want the support over here. So you have to look for a racerback that's up here. The higher, the better. I came across this recently. It's a compression garment. It's made by a company called DM Orthotics. For those who are from the UK, this is actually a company from the UK, and I had the opportunity to look at their compression garments, and they're pretty amazing, I should say. They're not marketing it into the US at this time, but here's Pam's email. She's told me that if anybody is interested, they can to email her, and she can help people in the United States or in any other country to get it. The thing about this compression garment is that this custom designed to each patient. So Pam, I assume, will ask for your sizing, and they're custom designed. They also have reinforcement where you need the reinforcement most, and they come in different types. So I just showed you the one for the upper back, but there's one that comes for the lower back, and so on. This is another one that's it's an athletic wear company that's in the United States. It's called CW-X. I have no idea why they call themselves CW-X, but if you go to Zappos, you should be able to find them. The thing I like about this is it has kinesio tape built into it, so they have reinforcement made into it, and this really helps, makes a difference. They have it both for the upper body and the lower body, and then they have one for legs also. Spine instability. The spine is made up of multiple joints. Each level of the joint, each level of the spine has 4 joints, and these joints are held together by ligaments and muscles. And if these ligaments are not doing their job, then the muscles have to tighten up. And when the muscles have to tighten up, they have to do a whole lot more work, and so they tend to hurt. In the thoracic spine, the thoracic spine is a little unique because that's where the ribs meet the spine, and that's called costovertebral joint. That's where the rib meets the spine, and there are actually, each rib makes 3 joints with this thoracic spine. So if these ligaments at the ribs are not strong enough, are lax, they tend to have subluxations of these ribs at the costovertebral joints. It's a pretty intense pain, mostly in the upper to mid back. Lower back, they have subluxations of the facet joints. These are again small joints in the lower back. Sacral joint, I'll talk a little bit more about it. And usually it's more from uneven posture, in the way people with EDS stand, and they're uneven, and it throws their SI joint off. Kyphosis is the spine poking backwards. Scoliosis is when the spine is sideways. In patients with EDS, scoliosis is much more common. And the part is that the thing about scoliosis in these patients is it's dynamic. So they may have scoliosis one day, and then it may not show up the next day. But kyphosis, scoliosis, lower back pain may be a symptom of tethered cord syndrome. and we'll get into that a little bit more later. I just wanted to show you in this slide the muscles. Look at the amount of muscles that are in the spine, and if the ligaments in the spine don't do a good job of supporting the spine, then these muscles have to work extra hard to support them. And so if they keep working extra hard, then of course they start to spasm up and start to hurt. So how do you treat it? Postural correction is extremely important. Compression garments, muscle strengthening. So you want to strengthen those muscles because you can't depend on the ligaments to do their job. I'm not a huge fan of steroid injections into these joints, but there is a role in some patients, in very select patients, you can do steroid injections. Remember, the pain is from the muscles. The pain is from the joints moving. Steroid injections help inflammatory pain. So if there's inflammation, then of course the steroid injections will help. But the real cure is to stabilize these joints. This is a brace that I like to use for my patients. It's called the Lumbo Lady. This is more for the SI joint. It sort of covers the lower back and the SI joint. It's a good support for the SI joint, particularly. It's made by a German company called Bauerfeind. You can buy them in the United States. You can pretty much buy it in any country. Okay, so moving on, since we're on the spine, I wanted to touch a little bit about tethered cord syndrome. The tethered cord syndrome is one of those mysteries that we find in EDS. This picture is the normal picture. This one over here is a tethered cord one. So over here you can see the spinal cord actually ends at L1. After that, it's just a filament. There are no nerves. It's mostly just a thread hanging down. And this thread then goes on to hang loose over here. And when we grow taller or when we move around, the whole spinal cord, the brain and the spinal cord move together with our spine. And that's one of the reasons why this is hanging loose and is not tethered down here. In some patients, it can get tethered. So this little phylum over here is now tethered to this over here in the lower back. Eventually, what it does is it pulls the spinal cord, and so now, when it was at the L1 position, it's now at the L3 position. So it's been pulled down, and when it gets pulled down, it pulls the nerves with it. Oftentimes, on an MRI or after surgery, you can see a fatty deposit over the phylum. An MRI is not a very useful diagnosis for tethered cord syndrome. Most cases of tethered cord syndrome that I have seen, the MRI looks pretty normal. Clinical symptoms, patients with tethered cord present with are low back pain. They have what is called a neurogenic bladder. They have leg weakness and sensory loss. They have weakness to their legs. They may do toe walking or heel walking. A neurogenic bladder is when they have increased frequency, so they go often. They have urgency, can't hold it. And then they also have a feeling after they've emptied their bladder, they get a feeling like they didn't quite empty it, they're not sure. And sometimes they can present with incontinence. So these are the symptoms. Together with this neurogenic bladder, leg weakness, sensory loss, musculoskeletal abnormalities, toe walking, heel walking. So basically back pain with non-specific leg pain and symptoms of neurogenic bladder is an indication, is a suspicion for tethered cord syndrome. Now, the way a neurogenic bladder is diagnosed, it's done by a urologist. They do what is called a urodynamic study. They do a urodynamic study. They find out how the bladder is functioning, and that kind of helps the neurosurgeon or the urologist understand if it's a neurogenic bladder. I did touch on pain from the ribs, but I wanted to explain what's the reason why people have rib pain. So patients with EDS often have what is called what is rib pain. The ribs are very tender. They have a feeling of what's called air hunger. So they might be just sitting around watching television, and then every so often they'll take a deep breath, like as if they forgot to take a breath. It's like almost like a sigh. They have tenderness to the ribs. The ribs are very tender to touch. And obviously, they've been tested for any problems with the heart and lungs. That has been ruled out. And again, like I said, each rib makes 3 joints in the back, and so any of these joints can start to hurt. What really happens in normal physiology is that when we breathe, so when we inspire, so when we breathe in, these ribs move up. And there's a big muscle here called the diaphragm, and this diaphragm moves down. When we breathe out, the ribs move down and the diaphragm moves up. The reason I'm showing this slide is because I wanted to show you all these things have to work together. And between these ribs, you can see there are a bunch of muscles over here. Actually, there are 3 layers of muscles between the ribs. Each rib, there are 3 layers of muscles. The reason I brought this up is because there's a whole lot of coordination going on over here. There are about 20 ribs that have to work in harmony for us to breathe in and breathe out. The diaphragm has to work in harmony for us to breathe and breathe out. Now, if the brain, and we'll talk about proprioception later on, if the joint position sense of proprioception is poor, then these ribs are not moving in harmony. And when they don't move in harmony, then when they're not moving together, one rib might be moving faster than the other rib, or the brain doesn't know this, and this rib may be moving down, then these muscles get overstretched and they present with tenderness to the ribs. So pain to the ribs can be from subluxation of the joint of the rib itself in the back. There's usually not much subluxation in the front. It's kind of difficult. The pain in the front from the ribs is usually because of poor proprioception or joint position sense. Some of the muscles that are used in breathing are also part of the lower back. That's why they often tell you to do breathing exercises when you have back pain. How do you fix it? There are a bunch of things that can be done. They're pretty cool, actually. One of them is you lie on your back. These knees should be bent. So you bend your knees, put a book on your belly button, and breathe in and breathe out for 20 minutes, moving the book up and down. That's all you have to do is move the book up and down. It doesn't have to be 1 inch. Just making it move up and down is plenty. And do it for 20 minutes a day. And that should help coordinate these ribs to get back your proprioception. This is a little more difficult to do. You lie on your stomach on the floor. You put a 1.5 inch rubber ball under your belly button. The belly button is actually the level of the diaphragm. So that's where you put the rubber ball. And then you lie comfortably on your stomach with the ball under your belly button for 20 minutes. And that's all it is. If you get uncomfortable, then use a smaller ball. These are pretty interesting. If you are driving, singing in high and low notes, so singing, use both high and low notes. You can use a wind instrument like a recorder. That does help. The good news about strengthening the chest muscles, it helps with rib pain and the lower back pain at the same time. So moving on to the arms in EDS. Arm, of course, is the reason I see pain in arms is from shoulder subluxations, dislocations. I just wanted to touch a little bit on subluxations and dislocations. Subluxations is when the joint kind of slips out and slips back in, and it can happen 20 times a day. Dislocation is when the joint comes out and it stays out and it has to be pushed back in. So they're just different degrees. Most people with EDS have more subluxations than dislocations. And they can have pain from what is called thoracic outlet syndrome. They can have pain in their elbows from tendonitis, bursitis. They can actually have subluxation of the elbow joint. There is a joint over there from the radial head that can sublux. And then pain from wrists and fingers, again from muscle pain and tendonitis. Now, the human body is designed such that if the ligaments are loose and lax, then the muscles around that joint tend to tighten up in order to hold that joint in place. And this applies particularly to patients with shoulder pain. And so if the shoulder joint subluxes, then these muscles tend to tighten up. These muscles are part of the rotator cuff group. They tend to tighten up to stabilize the shoulder. They also have pain from what is called as thoracic outlet syndrome, and I'll explain that to you in a minute. Patients with thoracic outlet syndrome present classically with these symptoms. So they have pain in their upper back. It goes into their shoulder blade. It goes into the shoulder and down the arm. And it may either go into, over here they've shown the thumb, but it can go into either of these fingers. It could go into these fingers also. Typically, and in the front, in some patients with thoracic outlet syndrome, it can come into the front of the chest also. Typically, this would look like, oh, maybe this patient has a neck problem, has some kind of a disc herniation or something, and they have pain shooting down their arm from their neck. But in thoracic outlet syndrome is very easy to diagnose in an office. This slide is to show you what exactly does thoracic outlet syndrome mean. This is how the shoulder joint is made up of. This is the collarbone, okay, and this is the first rib over here. And these are the muscles over here that support this whole structure together. So this is called the pec minor or pectoralis minor muscle, and these are called the scalene muscles. But what happens is that between this collarbone and the shoulder and the first rib, there's a gap, and in this gap are nerves, arteries, and veins that travel down the arm. If this gap between the collarbone, and the first rib were to close down because of joint laxity or shoulder joint laxity, then these nerves or the blood vessels get pinched, and that would cause pain shooting down the arm. In some cases, the pec minor gets tightened, and when that gets tightened, it squeezes these nerves and blood vessels going down the arm. So thoracic outlet syndrome is basically the nerves and blood vessels going down the arm getting either squeezed between the first rib and the collarbone or behind the pec minor muscle. There are certain thoracic outlet exercises that the physical therapists do. Kinesiotaping is a good way to go, stabilizing the shoulder, and if all else fails, then it's surgery. And often this surgery is often done by vascular surgeons or thoracic surgeons. They do this thoracic outlet surgery. This is a sample of what is called kinesiotaping of the shoulder joint. I apologize for the spelling mistake, but this is a sample of kinesiotaping of the shoulder joint. Most physical therapists are excellent at doing that, and it's a good technique to learn by yourself also. Once you figure out how it is done, somebody can help tape you, and it does help a lot. Moving down to the hands and wrists. Common reason for pain in patients with EDS. what happens is patients have poor proprioception. And what that means is that the brain isn't getting any signals from their fingers as to the exact position of their fingers. So they tend to hold their pen very tight and they press down hard on paper. So they use a bunch of fingers. They literally white knuckle the pen, and then when they write really hard, and you can actually, they emboss right to paper. They apply an abnormal pressure. The problem is that the hand is made up of small muscles. These are tiny muscles. They have to work extra hard. On top of that, these joints are loose and lax. So joints of the hands and fingers are loose and lax, which doesn't give them a whole lot of stability. And then these muscles have to work extra hard in order to just do a simple task like holding a pen or a toothbrush or a paintbrush. One of the ways to get around that is to use a dense foam padding. It's like a tube that goes around the pen. It's made by a company called Ableware. You can use it for pens, toothbrushes, forks, knives. And if this is not possible, then fingerless compression gloves really do work well. You can pick them up at any store. They're really nice. The way the brain figures out joint position senses when there's something in contact with skin around the knuckles. So if this contact of this material with the joints and the skin is where the brain gets its feedback. It can figure out the position of the joints from the sensation from the skin. So using a compression half finger gloves does help. And then if all else fails, of course, you have to stabilize the joints of the finger. So there are particular joints that are subluxing and dislocating. There are splints that you can get. Unfortunately, the splints that are actually approved by insurance companies are made of plastic, which is fine. But after some time, these plastic splints start to deform. So getting a splint made of metal is a good idea. And they make them for all kinds of joints. So they make them for this joint, they make them for this joint, and this joint, and even one for the wrist. So while we're on the topic of splints and braces, I wanted to explain a little bit on that. The braces, what they do is they maintain joints in a neutral position. So over here you can see this brace. This splint has maintained this finger in a very neutral position. It avoids hyperextension. They help with joint position awareness. Remember how I said that when something's in contact with the joint, the skin over the joint, that's how the brain figures out position of the joint. So it helps with that. My usual recommendation is start using them gradually and then decrease their use as you gain strength. The problem with braces is that most people have a misconception about it, is that braces make people weak, make the muscles weak. They cause atrophy of the muscle, which is an absolutely wrong concept. One, as you can see this brace, for example, the brace does not cover any muscles. Braces are not supposed to cover muscles. They are supposed to cover joints. So this muscle is still functioning. The muscles in the leg are still functioning. In fact, they function better because now the joint is stabilized. So in fact, braces that stabilize joints actually help muscles move better and strengthen them. So, and braces are generally not tight enough to stop muscles from moving. So the concept that braces make muscles weak is not actually true. Moving down to legs. So in the lower half of the body, the thing that I like to do is to start with the feet and ankles, because if the feet and ankles are not stable, then that makes the knee unstable, which then makes the hip unstable, which then throws your SI joint off, which then throws the spine off. So everything starts from the feet up. It's like a Jenga tower. If this is not stable, then this becomes unstable. This is the hip becomes unstable, which makes the spine unstable, and so on. So it's important to really, so I'm going to start with the feet first. I wanted to show you what flat feet look like. The difference is that when you place the foot on the ground and put weight on it, it becomes flat. When you lift it up, then you can see an arch. So oftentimes patients come and tell me like they have a beautiful arch, which they do, but when they stand on it, it gets crushed. It's flattened out. But what happens is that not only does it interfere with the gait, but it also throws your ankle off. So over here you can see how the ankle is, this ankle is going in this direction. See how this is poking out over here as compared to this, and how it's making this ankle unstable over here, turning out like this. That's the problem with flat feet. So when this person walks, you can see there's just no stability over here. It's like it's like walking on jello. This is what ideally it should be. Ideally, this is what the normal foot is. When the foot is, when you have a flat foot, it sticks out this way. We need to push it back. We need to stabilize the ankle. It's called excessive pronation. Now, I'll get into what things that can be done, but barefoot walking is a great way to do that. So what happens is when you walk barefoot, you actually claw your toes. When you claw your toes, you make your muscles have to work extra hard, and it strengthens those muscles. Repeatedly rising on your tiptoes, it strengthens the muscles in the foot. Ankle raises by lifting the heel, descending slowly in a controlled way. Footwear, this is extremely important. There's only one word for it: sneakers. You have to wear shoes that have laces on them, fastenings that should hold, that grip your foot together. Having a cushion midsole helps a lot. Sneakers nowadays are very well designed for this. Most patients with EDS that have come into me have told me that they like Brooks and Asics. Apparently, these two companies make their sneakers the best. For flat feet, this is again a German company that makes these. They do have a US branch. The company is called Pedag, and they make these soles for helping with flat feet. You can get custom designed orthotics. The problem with those are they're extremely expensive. So this is one of them. Of the many orthotics that I have looked at, this is the one that I've liked so far, but I'm sure there are others out there. Remember that ankle, how that was pronated? This is a really nice ankle brace. It's a figure of 8. It stabilizes the ankle, keeps the ankle in a very aligned position. It's again made by Bauerfeind. Moving up to the knees, this is a hypermobile patella. As you can see over here, the patella swings. Your patella is not supposed to swing a lot, just a little bit. But when the patella swings, it pulls on these muscles. So when it swings this way, these muscles tighten up. When it swings this way, these muscles tighten up, and that can cause pain up in the thigh. This is a hyperextended knee joint, and you can see how these skin folds over here. That's the hyperextended knee joint. You can see that over here. Now, this is a very unstable knee. Especially this knee is very unstable. It's not the weight of the body should be going straight down. In this case, you can see how the weight isn't going really straight down, and it puts extraordinary forces on these knees. It's going to be there on the slide, but this is a technique for kinesiotaping the knee joint in EDS. This was an article that was published in 2015. It's a pretty decent way to do it. You can do it yourself. This is a knee brace that again aligns the knee together and keeps it together, stops it from hyperextending. So Ideally, a knee brace should have 2 straps above the knee. Remember, the problem with the leg is that our legs are conical, so it's thicker up here, thinner over here, and then it becomes thin over here, and then thicker again. So it's really not a cylinder; it's conical, and so you need 2 straps on the top, you need 2 straps on the bottom, and then you need a little donut that holds the patella in place, and a metal strut that comes over here, is inside here, and that prevents the knee from hyperextending. This is a new brace that I've just come across recently. Really like it. It's got a scary name called the Gripper. It's a wrap around brace. So instead of tugging and pulling a brace up the leg like this one, this has to be pulled up the leg. Over here, this opens up and you wrap it around your knee joint. We're getting some good results with it. A common cause of pain in the leg is this joint. It's called the tibiofibular joint that causes pain. Sorry, it's called the tibiofibular joint. So the leg has 2 bones, and there's a joint over here, just below the knee on the side, on the outside. There's a joint here called the tibiofibular joint, and that joint, and that there's a nerve over there. When that gets inflamed, it causes pain in this distribution. And if it gets really worse, it can cause foot drop. Symptoms of foot drop are when you walk, you tend to stumble on your toes. This is to show you what I mean. This is the normal anatomy. So this is the leg is made up of 2 bones called the tibia, and this is the fibula, and that's the joint here. And like all joints, this joint can sublux. When this joint subluxes, then it bangs on this nerve called the peroneal nerve. So when this joint is subluxed, you can see how this nerve is getting inflamed over here. And when that nerve gets inflamed, it causes pain down the side of the leg. It can cause pain down the side of the leg, and that nerve is also responsible for lifting your foot as you walk, which causes foot drop. This is a quick note on foot drop. On tendinitis and bursitis. This picture over here is a normal joint, and so these are 2 bones. These are 2 bones that make a joint. There's a capsule around it, and you can see there's a muscle with a tendon that goes over it. Which is great, because now when this muscle shortens, it pulls this bone up, and that's how our joints move. The problem is that this muscle is lying on a bone, and when it lies on a bone, it can get damaged. So there's a little pocket of fluid over here. It's like a lubricant, and this pocket of fluid is called a bursa. And this bursa sort of lubricates it, so it allows the tendon and the joint and the muscle to move smoothly. If for any reason the bones sublux, so this bone moves down, this bone has moved out of place, now the pressure on the muscle and the tendon there's an extraordinary force being applied on the muscle and the tendon. So this pocket of fluid starts to get inflamed, and that's called bursitis. The reason I brought up this slide was because of this. The treatment of a tendinitis and a bursitis is not putting Bengay on it or some sort of a steroid injection. The treatment is really to correct that joint displacement. So this joint, if you correct this joint subluxation, that should help the joint come back to its proper position and take away the force. So correct posture is important. Avoid repetitive use of the joint and maintain proper balance. Sacroiliac joint pain. This pain is actually usually around the lower back, in the buttock region, and it may go down the legs. Does not go below the knee, but it can also be in the groin. And that's the distribution. Often, the most common distribution is right at the buttock fold over here. It sometimes goes down the leg, but usually not below the leg. It may or may not go into the groin. The reason the SI joint acts up is because of a leg length discrepancy. And the leg length discrepancy means that one leg apparently is shorter than the other. And that can happen if, say, for example, there's a problem with this leg. There may be a subluxation of the ankle joints. There's a flat foot here, or there's pain over here or something. So the pelvis gets tilted, and when the pelvis gets tilted, this is the SI joint. And this joint, ideally, when the weight of the body comes down, it splits into two, 50% to one side, 50% to the other side. But in this case, there's going to be more weight, more pressure going this way and less pressure going this way. And so this SI joint starts to act up, which means that the treatment over here would be not wearing just the brace, the lumbar lady brace that I showed, but also fixing any length leg discrepancy over here. This is again a same picture of the same brace, the lumbar trained lady brace. It's a good brace for the SI joint. So this kind of ends some of the EDS stuff. Let's talk about some of the other weird stuff that shows up on EDS. One of them is called POTS. Dysautonomia, it sounds like a dinosaur that died, but this is really just a fancy name for a bunch of medical conditions that affect the nerves that control the automatic functions in our body. And so dysautonomia comes from the word dysfunction of the autonomic nervous system. One of the common dysautonomias is called POTS, postural orthostatic tachycardia syndrome. It's not the commonest, but this is one of the most common ones that we see in EDS. What do patients with POTS present with? They present with fainting, dizziness, heart racing, fatigue. This is a biggie. Fatigue. They can have headaches. I showed you how they have headaches. These headaches get worse when they stand. They get better when they lie down, but they don't get as better when they lie down as in CSF leak. They do get a little better. They have difficulty maintaining their body temperature. So everybody in the room is sitting comfortably, but they are the one with 64 blankets on, or they're in shorts. They have brain fog. This is pretty significant. Brain fog. Some of them get a constant feeling of anxiety. They can have stomach pain and a fatigue. Again, they wake up feeling tired, which is called non-restorative sleep. What happens in EDS, in POTS, is in EDSers, is that when they stand, blood pools down to their lower extremities. So their lower extremities actually turn darker. You can see that when you stand, you'll see hands and feet turn dark. This triggers their nervous system, the autonomic nervous system, which is responsible for controlling blood pressure, and which is also the same nervous system that controls flight or fight. So their nervous system is now, this autonomic nervous system is now working hard to push this blood back up to their heart and then onto their brain. And so it is a constant overactivity of this autonomic nervous system. And that's what's called POTS. And these are the symptoms that they have is dizziness when they stand up, fainting, heart racing, fatigue, and brain fog, because they're not getting enough blood to their to the upper part of the body. A really good websites to get this information is one of them is called the Dysautonomia International. It's an organization that I really love. I put a link over here. They have lots of information on POTS. They do have, which I found was very cool, was high salt diet recipes. And there's another website called the EDS Awareness. This is their website, Chronic Pain Partners. They have lots of webinars actually on these same subjects. Anyway, so the problem with POTS is that because they have this constant feeling of dizziness and dizziness that makes them, and they're already unstable to start with, so they become even more unstable. So their joints have to work extra hard, their muscles have to work extra hard. On top of that, it worsens their pain and fatigue. Now, the relationship between anxiety and POTS was that, remember I said how this autonomic nervous system has to work extra hard to pump this blood back up to the heart and then onto the brain. This is the same autonomic nervous system that is responsible for flight or fight, which is the same as anxiety. And so oftentimes this anxiety can happen from POTS and is not coming from their brain. The diagnosis of POTS is the criteria is that their heart rate increases by 30 beats per minute when they have been standing, but the blood pressure does not change. And in kids, it should be, or in adults also, it can, if the heart rate reaches 120 beats per minute. In kids, if the heart rate increases by 40 beats per minute. The way I like to do it is we do the what is called orthostatics in the office. They're lying supine for 5 minutes, and then standing up, and then standing up for 10 minutes. I check a blood pressure and a heart rate. There's something called a Q sweat and a tilt table test. If you have POTS, a tilt table test is a nightmare to have. This is what it typically looks like. You can see the blood pressure is pretty much stable. This is lying down. This is standing. This is standing for 10 minutes. The blood pressure doesn't really change a lot, but the heart rate has jumped up from 80 to 215 to 108. Treatment of POTS is increased salt by mouth, increased electrolyte fluids. Something I like is called banana bag. You can use banana bag. It's got potassium in it, which does help. Compression tights. I showed you some compression tights. You can use an abdominal binder or beta blockers such as metoprolol. Exercise is key over here, but the exercise has to be done lying down. And there's something called the Dallas protocol. You can Google it and find out. These are 3 videos that I put over here where you can exercise in the pool. These are the types of exercises that can be done in the pool. These are exercises that can be done lying down. These are videos that you can check. They're also there on the Dysautonomia website, Dysautonomia International website. Also, I have some more exercises in the pool. There's another slide with that. One last thing, POTS is, like I said, POTS is not about blood pooling. It can also happen from an autoimmune condition. This is just some nerdy stuff I put in there. It can be from autoimmune conditions where patients develop antibodies, and these are all the complex antibodies that they can develop. They may respond well to what are called IVIG infusions. That's a whole different discussion. So just to recap, fainting, dizziness, fatigue. Moving on to mast cell activation syndrome, or MCAS. Mast cells are typical are cells found in the blood, okay, and they're part of our defense mechanism, are part of the immune system. When these mast cells detect an attack or like an infection or something that's foreign to the body, they get activated. When these mast cells get activated, they're not happy. They release chemicals like histamine, cytokines. These are nasty chemicals that cause pain and fatigue and all sorts of things. The problem in EDS is that mast cells get triggered inappropriately. We don't quite know why they get triggered such a lot. And so because they get triggered so much, they produce a whole lot of histamine, cytokines, chemokines, and all the other stuff. Please do not confuse it with mastocytosis, which is a whole different condition. They present with rashes, hives, fatigue again. So we saw fatigue in a bunch of other conditions. There's fatigue, there's tiredness, there's muscle pain. Pain is a predominant feature of mast cell. There's a lot of pain here, bone pain, joint pain. They have abdominal bloating, palpitations, flushing, especially after a hot shower. Most of them have a constant feeling of having flu. It feels like they have a flu. Everything aches. They feel tired and yucky. This is called dermatographism, and you can actually do a scratch and write on it, and it'll show up. This is what a mast cell looks like in the blood. It looks really granular. There's lots of granules in there. They're large cells, and when these granular cells open up, they release these cytokines. They release histamine. They release like over 200 different chemicals, but these are the ones that I wanted to focus on today. The test for mast cell activation syndrome is not reliable. It does not mean if the testing is normal, then you don't have it. But these are the tests that I've listed over here, which I really don't I do them sometimes. I'm not a huge fan of these tests because it's really hard to get this test done. The diagnosis depends largely on a physician who actually knows what mast cell is. And it's a diagnosis is a lot of it is clinical. But if there's somebody who has had a biopsy sample from their GI tract when doing an endoscopy, they can ask for this. And biopsy samples are actually stored for many years after it's done. And so you can ask for them to stain it with what a stain called the CD117. These mast cells, you need to know the number of mast cells per high power field. You want the pathologist to comment about the morphology and the histology of these mast cells. Treatment, so antihistamines like Zantac, 150 milligrams twice a day. Any one of these cold medicines, all cold medicines are antihistamines. So any one of these can do the job. Claritin, Zyrtec, clemastine, rupatadine. Quercetin is a mast cell stabilizer. It's available over the counter. You can get it on Amazon. Ketotifen, you have to get it from a compounding pharmacy. Works beautifully well. It's a mast cell stabilizer. Cromolyn is another mast cell stabilizer. It has to be taken orally. It can also be taken nebulized. So in patients with asthma, it's easier to get that. Cromolyn is a very good mast cell stabilizer that can make a big difference. The more importantly is to find out the trigger. What's triggering these mast cells? Some of the things that trigger them are NSAIDs like ibuprofen, Motrin. Alcohol can trigger it. Narcotics can trigger it. Sudden body temperatures. Some of the inactive ingredients in pills can trigger it. One of the things you can do is you just have to work through them and find out which food or which substance is triggering it. A low histamine diet, there's something called a low histamine diet, so you can look at that. Look for hidden sources in foods, seasonings, dairy. So seasonings can do it, dairy can do it, eggs, grains. Gluten is a big culprit. Avoid beef products. Remember the cow that ate the grain, which ate the gluten, can cause that to happen. Same thing with chickens. Other methods is that are you getting these triggers through the air? Are we breathing something? So HEPA air filters in the air conditioning or pollen guards in the windows. And in a flare up, you can basically just do a nasal saline wash. I want to move on to abdominal pain, belly pain. It's very, 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 very common in EDS. What happens in these patients is that there is slowing down of the intestines. They present with alternating diarrhea and constipation. They have nausea, acid reflux, bloating, constipation, which are also features of POTS and mast cell activation syndrome. They can have prolapse, which is an EDS feature. Acid reflux is more from a mast cell activation syndrome. This is a diet that works really well in patients. It's called the low FODMAP diet. I have more details on it on the next slide. But if you're wondering what FODMAP stands for, it's over here. This is a stage 1, stage 2, stage 3 that I've put in over here. There's a link over here for what to look for in a low FODMAP diet. We've had some really great results with using low FODMAP diet in EDSers. Now, the problem with if the intestines are not moving well, then there's an overgrowth of bacteria over there, which is called small intestinal bacterial overgrowth, also known as SIBO. So now you've got the microbiome in the intestine is now altered significantly, which then leads to inflammation and then worsens pain and symptoms of POTS. Patients with SIBO present with abdominal pain, discomfort, bloating, diarrhea, weakness, and they're gassy. They have weight loss, they have vitamin deficiency because they're not absorbing these vitamins. They have an excess of folate because these bacteria produce folate. They have iron deficiency and low protein. The way they diagnose it is because these bacteria produce hydrogen and methane. So what they do is they do a breath test, which is really easy to do. You can actually do it at home, which detects the levels of hydrogen and methane, and then you can you can treat it from there. Elevated methane levels can be treated with statins, that is the drugs that they use for treatment of cholesterol. The one that they recommend most is lovastatin, which is also a component of red rice yeast, which you can get over the counter. And obviously you want to treat the dysautonomia and the mast cell because the intestines have to start moving. Treat constipation. Some of the drugs that are used to improve GI motility are, my favorites are Resolor. Resolor is not available in the US, it's available in Canada. Iborogast is a herbal medicine on mastinon or erythromycin. Avoid simple carbohydrates and think of pureed foods when treating SIBO. This is a strange condition called MALS, median arcuate ligament syndrome. What happens in this is, again, patients present with the same abdominal pain, belly pain after eating food. It can trigger POTS. The thing about this is that, I'll show you a diagram. This is, again, the normal anatomy. This is the median arcuate ligament syndrome. So this is inside the stomach, and this is an artery called the celiac artery, and it pokes its way through ligament under the ligament called the median arcuate. And this artery supplies blood to the intestine. Now, in median arcuate ligament, what happens is that this ligament, that it starts to pinch this artery over here, and it restricts blood flow. And that causes some of these issues of abdominal pain and bloating. But there is a second theory that is much more acceptable now, is that there is a nerve called the celiac ganglion, which kind of lives over here, right it lives on both sides. It's a nerve that goes to the intestines, and this nerve is known as is from the celiac ganglion. So when they have to do surgery for it, they do a surgical decompression, which is releasing the arcuate ligament, and then they also remove the nerve, the celiac ganglion. And if it's treated late, then these patients may need IVIG infusions to treat their POTS. Pelvic pain, dysmenorrhea. During menstrual periods, the hormones are thrown off, which really makes the ligaments much more weaker. It also triggers mast cell activation syndrome. It triggers loose joints. It triggers pain. It triggers POTS. So the best recommendation here is to go on a birth control pill to stop periods. Interstitial cystitis, which is bladder pain. This, I think, is mostly from mast cell activation syndrome. There's mast cells living inside the bladder. A good way to treat that would be to try cromolyn or ketotifen. There's a drug called palmitoyl ethanoyl amide. It is sold as PEA or P-Pure. It's over the counter. There's some literature on it that it does help interstitial cystitis. I'll have more details on this later on. Vulvodynia, which is vaginal pain. This is usually a feature of mast cell activation syndrome. So the vaginal wall is inflamed. The first thing to try is Benadryl, either a Benadryl douche or a cream, or you can do a cromolyn douche or a cream. This, again, a compounding pharmacy can make it. Benadryl douche, you don't need a compounding pharmacy, but these have shown to be very effective for vulvodynia. EDS and children. Again, kids present with dislocated joints, they have chronic body-wide pain, they have bruise easily, they have belly pain, they have fatigue, and then they have bleeding, which is for no reason, small injury, they have bleeding. To an emergency room physician, that looks suspicious of medical child abuse. And this is a bit of a sore point with me. And so these patients get diagnosed with conversion disorder, which I don't even know if it's a real condition. They have Munchausen by proxy, which is, again, a made-up condition. And they're diagnosed by physicians who have no training in psychiatry. And then there are psychiatrists who have no training in EDS or pain conditions or diagnosing these conditions. My recommendation over here is please research the facility carefully before taking your child. Make sure the facility has trained physicians who know EDS, POTS, mast cell. Beware of hospitals that have hired this so-called medical child abuse specialist. Believe it or not, that is a specialty. So be aware of that. Now, about which kind of a hospital should one go to? Academic hospitals, the problem is that the chances are that you will meet a junior doctor or a resident who's kind of graduated last week, who's the least qualified to diagnose a complex medical condition. And that is where the problem lies. And these are the residents, these are the doctors who diagnose these people with conversion disorder and all that stuff. If you're able and if you can financially afford it, the best thing to do is to get a concierge physician. That's what I would recommend. Service dogs are invaluable. I get dirty looks from parents when I recommend that. Kids love it. Service dogs are trained to each person's needs, and I have had a number of patients, number of kids that have actually could go through college and school just because they had a service dog. Remember, service dogs are not pet dogs. They are doing a job. They are there to protect you and help you. It's really a good way to go. These are some of the organizations that I know. I'm sure there are lots more organizations that do it. But it's something that you must consider seriously if you have some of these conditions that we've talked about. Now, we didn't talk about how to manage pain. So managing pain is to find out what's broken. So once you find out what's broken, then fix so if you have a flat tire, fix the flat tire. So if there's pain from the shoulder joint, it could be from a dislocated joint, it could be a muscle spasm, it could be thoracic outlet syndrome, treat, or it could be all of them. So treating what's broken is the way to treat pain. In EDS, not just in EDS, we all go through what is called micro trauma. That means these are small traumas that we get repeatedly. Just getting out of a chair and walking down the stairs, you've just damaged a whole bunch of tissue. And of course, the body starts to repair it as we go along. But in EDS, tissue repair is hard, it's slower. And so they they break down easily because the tissue is not that strong. And then they also don't repair it as well, as fast. And so they tend to have more micro trauma. And that can happen from overstretching muscles, ligaments, or doing something repetitive like vacuuming or something. Macro trauma is pretty straightforward. You've dislocated a joint or broken a bone. That's micro trauma. This is macro trauma, and this is micro trauma, little tears in the ligaments or the muscles that you can't see. So use a mix of treatments. So if somebody has knee pain, there's no one treatment. So, stabilize the knee with braces, then you strengthen the muscles, then you use medications, whether they are pills or topicals. Expect to get at least 10% from one treatment. So if you get 5 such treatments, so you have a total of 50% relief. Joint position sense. So what happens is in our joints, we have sensors, and these sensors then tell the brain exactly where the joint is. And that helps us in being able to stand and move and walk without stumbling or bumping into things. And we know that EDSers are kludgy is because they have poor joint position sense. And then I showed you how they hold things, how they hold a pen and all that. And what happens over here is, so this is what I just explained to you. Now, wearing something that is skin tight over the joints helps the brain figure out where the joint is. Or exercising in water. Again, water touching the joints, water touching the skin makes that, and it also makes you lighter, which takes the force, the pressure off the joints. Some of the proprioception exercises are balance board, wobble board, Stokes standing. They're all here. This is, I know you guys can't see me, but I'm the guy in the front. This is again the CWX that I showed you, CW-X. You can see how cool, this is so cool. You can see these, this is the kinesio tape that's built into it. And of course, it also helps with POTS. So it helps with POTS, it helps with joint position sense. This is a proprioception. This is what I was trying to explain to you earlier. So as we walk, there is signals that go up from they go up the spinal cord into the brain, and then the brain and then turns down, sends signals down. Exercises for EDS. So I showed you some videos. I mean, I gave you the links for some of those videos. I think those videos are great. They'll give you all that you need for exercising with EDS and POTS. Those are wonderful exercises lying down or in the water. The only thing I want to stress on is start really low, really low, and progress very slowly. We're not trying to go in for any championships over here. Avoid extreme stretching. Focus on strengthening and avoid joint stressing or loading your joints too much. Now, this is what I wanted to show you, was that also remember that you want to stay within your range of motion. So if you can bring your leg up till here and here, you want to stop short of the extreme. You don't want to go all the way there. You don't want to go all the way here. Stop short, because going all the way, if you flex your leg all the way, then we are overstretching our ligaments here. We are overstretching our muscles here. Swimming is by far the best. Exercising in water is the best, but swimming is not. Swimming, you don't want to, this is really stressing the shoulder joint here. It's going to mess up with the neck joints over here. Neuromuscular taping or kinesio taping. The reason I bring this up is because it has a fingerprint pattern over it. And this adhesive over here, it's like having fingers that are gently pushing on the muscle and the skin. It's designed to stretch. It's porous. You can leave it on for 5 days. I don't recommend 5 days. I recommend changing it every 3 days. It helps the sensors in the skin, so it helps with proprioception. It helps reduce swelling. It relaxes the muscles. It stabilizes the joints. For those who have mast cell, so this is a common problem. Those who have mast cells, putting this tape on causes a reaction. These are some of the recommendations. There's a cream called Cavalon that 3M makes. You can spray this on before putting the tape. There's something called Leukotape. It's not exactly my favorite, but it's better than nothing. Or you can just get the El Cheapo brand of milk of magnesia, put it on, let it dry, and then put the tape on. Feldenkrais technique, if you can find a Feldenkrais provider in your area, then that would be a wonderful way. This is a technique that lets you, it helps with joint position sense. It's very benign, it's not strenuous at all, and it helps with joint position sense. For some reason, I've contacted these people and they are not really interested in EDS. I mean, I don't know, but if you can find a provider, and that'll be great. Just to make sure, with medicines and with exercise, start low, go slow. Okay, so I just want to talk about a few things that I've seen with experience. This is a really cheesy name to this patch. It's called Pain Terminators. I wish they had a better name for it, but it's got a bunch of herbs in it, a ton of herbs in it. It works. That's all I can say. It works. I don't know how it works, but it works. My patients love it, and I've tried it a bunch of times, so it's worth it. You can pick it up on Amazon. This is, remember I told you about the palmitoyl ethanolamide, PEA. It comes as a cream and it comes as pills. The pills work well for interstitial cystitis, but the cream, it's actually made in the US. It's called sutamide. If you Google it, you should find it. It's this company that manufactures it. It's great. I'm sorry, it's not great, but it's okay. So if you have a joint pain, it's something to use. Again, it's just one little thing to add to your toolbox. I wouldn't say it's a miracle cure, but it's pretty decent. This is good news. This is coming in. We've got there's something called CGRP antibodies. This is brand new stuff. It stands for calcitonin gene-related peptide. It's a protein that's produced in the body that's involved in transmission of pain. In the last few months, there have been 2 such CGRP antibodies that have been approved, and I believe there are a few more that are being approved. So far, they're only approved for the treatment of migraines, but I have my fingers crossed that it'll get approved for other pain conditions. but this is something to consider. CGRP antibodies. I'm a little excited about trying these. Again, this concept about no pain, no gain, yeah, that doesn't work. It's baloney. I do not want you to exercise to the point of no pain, no gain. Okay, I want you to stay under that limit. Fatigue in EDS is huge, especially in the younger population. There are a gazillion reasons to have fatigue. EDS itself causes fatigue, POTS causes fatigue, mast cell activation syndrome. Drugs, some of the medicines cause fatigue, pain itself, poor sleep, mitochondrial dysfunction. These are mitochondria are powerhouses. They are rechargeable batteries in the body, and sometimes you can have these rechargeable batteries not work as well. They all contribute to fatigue. Median arcuate ligament can cause fatigue. Sleep apnea can cause fatigue. Hormonal. A lot of patients have hormonal issues because of POTS. There's not enough blood getting to the pituitary, and so they develop this low blood flow to the pituitary. Then that causes less hormones to be produced. So, oh boy, let me go through all of these. This is so EDS, POTS, and mast cell activation syndrome can cause all of these or any of these combination, and one has to just figure out which one it is and take one thing at a time and start treating it. Like mast cell can actually trigger POTS, and then so treating mast cell makes it really critical, and then at the same time treat POTS, and then at the same time work on EDS. Quickly want to touch on medical marijuana. The human body has two types of receptors, CB1 and CB2. CB1 is found in the brain, CB2 is found everywhere else. So which means that applying cannabis topically does make sense. It's a reasonable choice to try. Anecdotally, we know it works well in patients. There's no massive research to show that, but it does work well in EDS patients. Higher CBD levels and lower THC levels to think of. It comes in all kinds of forms. The beauty of medical marijuana is that it does not trigger mast cell activation syndrome, such as which NSAIDs and opioids do. Ibuprofens, Motrins can do it. Opioids can trigger mast cell activation syndrome, but medical marijuana does not. What I wanted to show you was CBD is for pain. It helps pain, and THC helps with the cognitive functioning. So you want to have during the daytime, you want to have something with a higher CBD level and a lower THC level. At night, you want to reverse that. So you want to have something with a little more THC and a little bit less or same amount of CBD. In practice, what we've seen, equal amounts actually work very well. Low-dose naltrexone is by far my favorite. It's a drug that's been around for many years. Naltrexone has been approved for many years, but when taken in low doses, it can help with pain, fatigue, especially the dose. I usually like to start my EDSs on a very small dose, like 1.75 milligrams, and then go up slowly to 4.5 milligrams once a day. It has to be compounded by a pharmacy, and it's not super expensive. Some of the side effects, and these are temporary, are insomnia and mild headaches, and then they go away after some time. I recommend usually trying it for at least 6 months. Usually patients have said that it increases their physical activity, it decreases flare-ups, they're not as acute, and they have better tolerance to pain. Now, patients with EDS have an abnormal response to medications. They might be sensitive, they have poor response. Muscle relaxants are not really that helpful. I don't usually use any of these. They don't really make a big difference, but you can add it if it makes a difference. Acetaminophen or paracetamol is one of the safest analgesics to use. It's not a very strong painkiller, but it does potentiate the effect of other analgesics. So you can add it to NSAIDs, or if you're on opioid, you can add it to that. and it does make a difference. It's pretty safe. NSAIDs are good, but they're not really safe. They do trigger mast cell activation syndrome. They're better used topically. You can combine it with acetaminophen or paracetamol at a lower dose. Opioids are very good analgesics. Most EDSs don't respond to narcotics for some reason. I'm not quite sure why. But if they're having flare-ups, if you're having a really bad flare-up, then it's worth a try. The only problem with long-term use is that it can actually make the pain a little worse, what is called as opioid hyperalgesia. Other drugs are anti-seizure antidepressants. These are only useful if there's any neuropathic component. That means if there's any nerve pain associated with EDS pain. And these are gabapentin and pregabalin. They do have side effects like weight gain and sleepiness. Tricyclic antidepressants are very good. They are worth trying it, especially at night, help with sleep. They do help with muscle pain. SNRIs are not my favorite, especially duloxetine is definitely not. This is marketed as Cymbalta. Too many side effects. It's a nightmare to come off this drug. Not my favorite drug. Milnacipran is sold in the US as Savella. It's a good one. It does not have as many side effects as Cymbalta does, but Savella is a good one to try. It's been approved for the treatment of fibromyalgia. SSRIs are like Prozac and Zoloft, not very helpful for pain. They do help some with POTS though. These are some of the treatments that we've come across in the past: oxygen, home oxygen, hormonal modulation, levodopa/carbidopa. This is sold in the US as Sinemet. This is my favorite drug for muscle spasms. Sinemet or levodopa/carbidopa does work well. Epsom salt has magnesium in it. 2 large cups of magnesium, Epsom salt into a bathtub works miracles. I like oxygen supplement, especially in patients who have a lot of fatigue. It is approved for treatment of migraines. So if you get any pushback saying that your pulse ox is normal, but most of us have migraines, so if you can, that's another way to go. You can use a non-rebreather mask, 3 liters to 5 liters for 20 minutes twice a day. It does help, makes a big difference. I like to try a mineral supplement that has a combination of CoQ10, L-carnitine, and creatinine. These are ingredients of mitochondrial cocktail. It does help with fatigue. This is the levodopa carbidopa that I was mentioning. In low doses, it does help with muscle spasms and dystonias. Thank you.
Thank you, Dr. Chopra. It's time for questions now, and we're going to do about 15 minutes of questions. If you have any questions, you are welcome to type them into the question box now, and we will get to as many questions as we can in the next 15 minutes. We've got a lot already, so go ahead and get your questions in. This webinar will be recorded for viewing later. It will be available on our YouTube page and our website. We will post on social media when the recording is up. Our next webinar after this one will be on October 24th. Dr. Nigel Burrows will be presenting on skin involvement in EDS and HSD. If you would like to sign up for that one, you can look for that sign up in the next, probably within the next week, we'll get that sign up out. So if you're interested in learning more about skin involvement in EDS, be sure to tune into that. You can also go to our previous webinars page and see any recordings from any of the previous webinars. We've had quite a few throughout the year. We do about 2 a week. So I hope that you were able to find some help with all of those. We have a lot of questions queued up for you. Are you ready?
Uh-oh.
Okay, we're going to do about 15 minutes of questions. The first question is, how can we determine if you have some cranial instability, and how do you bring that conversation to your doctor?
Okay, so I had the symptoms. You know, by the way, this was the exact same question that a bunch of doctors asked me last weekend in Utah. I'd given a talk. So once I showed you the symptoms, so obviously those are very non-specific symptoms. headache, neck pain, dizziness, and all that. One of the ways your physical therapist can actually help you, or if you have a doctor who does understand that, is to try and stabilize the neck with your hands. So the physical therapist or the dog physician, that's what I do in my office. Is what I do is I put my hands around their neck and I sort of stabilize it, and then I put a tiny bit of traction on it, just the slightest traction. And the patients know that the benefit right away. They like right away, things look clearer, their neck feels better, their head feels better. It's almost instantaneous. So that's the clinical test to do it. So look at the symptoms. This is a clinical test that I just mentioned, and it can be done by a physical therapist. They're really good at that. Or you can, or your physician if they know about it. Other than that, you have to get the usual CAT scan, the rotational films to look at it.
If you have heat sensitivity, how can you handle compression garments?
Well, these are some of the things that we have to live with. The ones that I showed you are actually athletic wear. They're made by athletic companies, and these athletic companies, the ones that most athletic companies wear that they manufacture, actually wicks away sweat, and it does not make you feel as hot. But it's again one of those things where you have to find, like, what's the happy medium. Like, should I be stuck in bed with POTS and not be able to move, or should I just wear that compression garment or compression leggings and put up with some amount of heat and be able to at least exercise and function? There's no great answer to it, but we do need compression. We do need it. There's no other thing that I know of. Or you can move to Alaska.
How do you feel about prolotherapy?
Oh, okay. Prolotherapy. The thing with, for those who don't know what prolotherapy is that what they do is they inject a drug, a mild irritant, and what it does is it causes the scar. It forms scar tissue. So they inject this irritant drug. It's usually dextrose that they'll inject it around the joint, and then the scar tissue then forms over there, and then that holds the joint together. Which in EDS, I think it's great for the smaller joints of the non-weight bearing small joints, like the hands, the wrist, even to a certain degree the elbows, and some in the spine, but not. It doesn't. I haven't seen great results for it with the SI joint, for example, or the knees or the weight bearing joints. But again, it can also depend on the person doing it. So there's some variation there. But there's no harm in trying it. The problem in EDS is that the scar tissue that's forming is the same scar tissue that got you into trouble in the first place.
We have a few questions about finding doctors in certain areas. Do you have any recommendations for how to find a doctor who is willing to try the approaches that you do, and where do you practice? So I had a question about that as well.
Okay, so for those who live in Hawaii, let me know and I can do a home visit. No, jokes apart, I'm in Rhode Island, which is a state in the United States. But the good news is that in the last few years, I've seen more and more physicians who are becoming more and more aware of this this combination of EDS with POTS with mast cell. You see, the problem is that you have to find there are cardiologists and neurologists who treat POTS but don't know anything about mast cell or EDS. Then there are people who know more about mast cell but don't know anything about the rest. So finding somebody who knows all of these. The good news is that there are more and more physicians out there who are now starting to understand this combination. There's no place, there's no repository which has a list of these things. I'm guessing the EDS Society might have some names. You can look up the people who speak at these conferences. For example, the University of Utah just had a talk on this exact subject, and there were some really amazing physicians who came there. So you can find these people there, and that's the only way to do it, is to go online and find them. But it's important to go to the right person, because if you go to somebody who does this urine test and blood test for mast cell and then finds that it made, and then obviously the test comes back normal, and then shows you the door saying that you don't have mast cell, that can get you into trouble. So you really have to go to somebody who really understands the nuances of this condition. You'll have to it's a question of just looking around, talking to people, and finding. There's no repository for this kind of names anywhere.
Can you speak a little bit about myofascial pain and how that fits into everything?
Sorry, can you repeat that, Jessica?
Can you speak about myofascial pain?
Yes, of course. Myofascial pain, just what it really just means is muscle pain. That's what it is. And EDSs do have lots of that. And there are many techniques to helping myofascial pain or muscle pain. The simplest ones, there are some really nice techniques called like myofascial release. There's strain, counter strain. These are some of the techniques that therapists use. If you can find someone who does, a lot of physical therapists do this myofascial release, strain, counter strain, that helps myofascial release. If you can also try for some very specific muscle spasms, you can try dry needling or trigger point injections. Those help also. But these are some of the techniques for myofascial release, myofascial pain.
What about Raynaud's syndrome? Is this part of autonomic dysfunction in EDS?
No. See, I know why this question got asked, because I get this a lot. When your toes turn red or your fingers turn red, it gets confused with Raynaud's syndrome, and it probably just is a manifestation of blood pooling. But there's no specific link between Raynaud's syndrome and EDS. There's no connection between POTS or any of these conditions with Raynaud's per se. But sometimes patients get diagnosed with Raynaud's because they're mistakenly diagnosed because they just have this pooling in their hands and it looks like Raynaud's.
When you have Chiari, are the symptoms persistent and continuous, or do they tend to be intermittent and come and go?
Come and go. It depends. Depends on the level of the Chiari. There are different types of Chiaris. The problem in EDS is that most often Chiari is associated with craniocervical instability. So surgeons who do treat Chiari malformation in EDS prefer doing a cervical fusion at the same time. And that being because they've not seen great results if you just do a Chiari decompression. But if it's not a big Chiari, then the symptoms do come and go. But in the later or the more severe types, it's more of a constant feature.
You showed a lot of braces. Do you have any suggestions for shoulders?
No. They do make shoulder braces, and shoulder braces are very cumbersome, and there's no harm in trying them. But the reason I never showed a shoulder brace was because I haven't seen any great results from it. It doesn't do any harm. So if you really have a really bad shoulder dislocation and it's really loose, then you can try it. It's kind of cumbersome to wear because the shoulder joint is a big joint. It's a very weak joint, and so they do need a lot of stuff around it to stabilize it. I experience-wise, I've not seen great results with it. But again, it doesn't do any harm in trying it, though.
If your blood pressure drops when your heart rate goes up upon standing, is that still POTS?
No. That then comes under the category of orthostatic intolerance, OI, orthostatic intolerance, or what is also called as neurally mediated hypotension. Neurally, Neurally mediated hypotension. If you go to the Dysautonomia International website, I believe they do have information on that, but the treatment is pretty much similar.
What are your thoughts on acupuncture?
I haven't. Number one, it's not going to do any harm trying it. Number one. Number two, it's a good modality to use, but it's not a fantastic modality. It's not going to make a world of difference. Believe it or not, I did train in acupuncture at one point, and I like it, but it's not something that I use for EDS. The other problem with acupuncture is that it does come out to be a little expensive because it's a lot of visits, and each visit then adds up, and insurance in most cases doesn't cover it.
What about chiropractic?
Chiropractic treatment, there are some chiropractors who really understand EDS very, very well, extremely well, but in general they don't. And if they don't understand EDS, they can cause more harm to you. So you have to be really very careful about which chiropractor you see. I've seen some who have done some good work. If you're looking for some kind of a manipulation therapy, look at osteopaths and look at somebody who can do craniosacral release, craniosacral manipulation. Craniosacral release, that works really well, and osteopathic manipulation does work very well. In fact, we have an amazing osteopath physical therapist over here who does a great job. But chiropractors, be careful. There are not too many who understand EDS. I would definitely not let them touch you above the neck, not to touch the head and neck. But just be very. I would be cautious.
We have time for one more question. What forms of magnesium work best for pain? Oral magnesium supplements, or do you recommend another form?
Okay, so this is subject. This is a question like I need to also know, because you see, for the longest time I thought oral magnesium works well, but now I've been told that no, the topical magnesium works well. But so I have an answer for this. If you're looking for something, or I would do both. Oral magnesium is called chelated magnesium. CHELATED, 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 magnesium works very well, but the best form is Epsom salt. If you can put Epsom salt, 2 large cups of Epsom salt in a bathtub, that works well. If you don't want it to trigger your mast cell, then you can make a paste out of it. Put a few drops, make a paste, and apply it over the muscle. It works very well.
Thank you so much, Dr. Chopra. It was a great webinar. I have to tell you that a lot of these questions that we were getting in were not actually questions. They were just telling you thank you for all the information you provided.
Oh, you're welcome.
There were a bunch of links in your PowerPoint. We had a few people asking if you could share those links. So if you could share those links with me whenever we upload it, we can include it in that recording, if that would be helpful for people. Thank you so much. Thank you so much, everyone, for joining.
Thank you very much for attending this webinar, and thank you for putting up with me for 2 hours.
Thank you so much. This is great, and a lot of people learned a lot, including me. So thank you so much. Thanks, everyone, for joining, and we will see you next time. Have a great day.
You too. Thank you.